I hope everyone's doing well. Lots of changes, obviously, in the last 24 hours, but none of them necessarily directly affecting us at the moment, although that could change considerably in the next hour and 45 minutes. So the Biden administration have a 2 p.m. Press briefing that Fauci is supposed to attend, where they're supposed to lay out their COVID plan. So today is COVID day for the Biden administration. I suppose they're spending the entire day just planning and releasing. There's another 10 executive orders that are forthcoming, at least one of which is going to be around the Defense Production Act. So we'll see what that holds. Obviously, that could bring some changes. The only thing that we know for sure at this moment is there is no secret stockpile of vaccine that is going to suddenly release. So that doesn't change our immediate future at the moment. And it sounds like, at least if you believe some of the new members of the administration's leaks this morning, that the plan that they inherited really probably didn't exist at all in their eyes. So they're starting potentially more from the ground than they even believed. Now, we'll probably hear more about that, I'm suspecting, in the next hour or so. But that means that while there's a lot of changes, there's a lot of things that we'll likely hear about mid-afternoon. Probably the direct effects on us and our delivery in the local region is probably not going to change dramatically, because there is going to be no urgent influx of vaccine, and there is going to be no immediate change as they potentially have to kind of rebuild this program to some degree. So we'll learn more, I'm sure, this afternoon, at least an itinerant plan of what we can expect. But at least the next week or so, we are going to be operating under this plateauing, if not decreasing, rate of infection. Fortunately, even though we are seeing more cases of variant coming into the New York state, we are still not seeing those variants in Western New York. Fingers crossed that stays as long as possible. So cases are going down. Unfortunately, we are in that window where the mortality is still going up. So that, we're still going to be living under that probably for the next week and a half at least. Our hospital census is going down. That is good, obviously. So the burden and risk to the hospitals is better, at least from COVID census. Now, the patients who are still hovering, I know Highland this morning, I think, was at something like 137% occupancy, which in the time I followed that data, which even preceded COVID, it had never been that high. So there's still the issue of being able to get these patients out of the hospital. But as far as new hospitalizations, we're not seeing as many as we were even just a week or so ago. So that is good news. Unfortunately, of those who are hospitalized, as you can see locally, our ICU volume has gone up. That is obviously a concern, because we're pretty much outstripping our ICU capabilities. So that, hopefully we'll see the plateau on that come very quickly. But as you can see, adding another 39 deaths. Granted, some of that is probably due to the way it's being reported now from the health department, but after a couple of days of saying 0, 0, and then all of a sudden adding 39, that's a big chunk. Nationally, you can see the percent positive, the rate of new infections is plateauing a bit. So that's good. We're seeing that nationally, state and local, that the rate of new infections has calmed. Obviously, as we talked about before, with at least potentially four variants now that are theoretically in circulation around the globe, the concern is that by March, we may see another spike in cases that is secondary to this variant. And with the vaccine availability lagging, the hope that we would be able to get ahead of the variants with the vaccine and vaccinating people obviously may not be able to be accomplished unless something changes dramatically here in the coming days to weeks. But otherwise, I think as much as could be going in the right direction right now, probably is. But we're still living inside of that risk of mortality that's going to follow from the Christmas, New Year's holiday window for the time being. Other than that, I don't think there's a whole lot else to see or share. The graphics really haven't changed dramatically. You're definitely getting a sense of, locally, that blue curve in hospitalization is going down. Obviously, that's new hospitalizations. That doesn't necessarily reflect patients who are lingering in the hospital because of difficulty with discharge. That remains a burden and a problem, but we're not seeing a huge change in the graphics otherwise at the time for the time being. Yeah, and this is still kind of Richter scales, but largely if we smooth it, we're in a plateau now as far as new diagnoses per day, which is good. Obviously, that should, within the next week or two, that should lead to some calming of the mortality, hospitalization, ICU overall. Regionally, I did not connect with our friends down in Tri-County today, but everything that I have seen has shown that the same plateauing effect that we're seeing here maybe is even more accelerated in various counties around the Finger Lakes region. So that is obviously good news. So as far as State of the Union, that's where we stand at the moment. Probably going to be a flurry of information changes over the next couple of days. I'm sure a lot of that will be highlighted in the popular press, especially as the Biden administration is promising daily, weekday briefings to try to be as transparent and communicative as possible. So I'm sure you'll be hearing about as much of this as we do in the coming days. And by the time we reconvene on Monday, there may be several things to talk about. The couple of things that are of interest for those who didn't hear this morning. So I think it was by AM this morning, we had already rejoined the World Health Organization, and not only rejoined, but we rejoined COVAX, which is the World Health Organization's collaborative effort, both around vaccine development, equity and disbursement of vaccine, but also testing and therapeutics. The real big thing there is that if there are other vaccines that are developed worldwide that are not part of the US industrial complex, if you will, it may give us greater access to vaccines that are being developed by the World Health Organization. Now, obviously there are concerns that some of those may not meet US FDA standards. We'll cross that bridge when we get there. But the hope is that that may provide us some access to resources that we otherwise would not have had by, even when we were in the World Health Organization, we weren't participating in COVAX at the beginning of the pandemic. But now that we are back in and fully participatory in COVAX, that may open up the door for more testing and therapeutic modalities and vaccine modalities than we've even had. The other interesting thing, this really comes out of the UK. We talked about this before, but if anybody has looked at the Pfizer vaccine graphic that was included in the FDA emergency use authorization approval, by about 12 to 14 days after the first day of Pfizer. I just haven't seen the data from Moderna. I'm sure it's actually fairly similar. But you start to see the separation of the curves and reaching that 90, 95% antibiotic protection or prophylaxis really occurred around about 2 to 3 weeks after receiving the first dose, and then just sustained and plateaued after the second dose was administered. So the UK health minister yesterday asked for approval to extend the second dose of Pfizer vaccine to 12 weeks after the first dose, based upon largely that graphic and that data. Now, the knock, obviously, is that Pfizer didn't do a demonstration product or project to prove that they could maintain and sustain a 90, 95%, 89% to be exact, prophylaxis after one dose for 12 weeks. Obviously, if they could, that would increase the circulating vaccine by as much as 25 to 30% more than we currently have in the marketplace, because we could extend that second dose out even further, which would allow us to actually catch up with some of the Pfizer production timelines that they've laid out. So we'll see where that gets us, knowing how attentive to the data the FDA is. This is kind of a surrogate endpoint that was found kind of secondarily just looking at graphics. It was not a primary factor, so usually that will be a no-go for the FDA. But in a time where vaccine is the limiting reagent at the moment, certainly we're looking for every avenue that we possibly can. So we'll see where that gets us. Interestingly, believe what you may, if other countries even were to accept a 12-week, even if the US did not, it may allow us to, now that Cuomo is trying to go out and buy vaccine directly from Pfizer, even if the vaccine supply was better or more available because other countries were adhering to a more delayed vaccination schedule, it still may increase the amount of vaccine available to and within the US. So we'll see where that goes. So that's really the only new thing. Again, don't know how much traction or effect that's going to have for us, but we'll find out here in the coming days, I'm sure. As for testing, we are probably now about a week from the new platforms going live. Those will be PCR platforms, high volume, high throughput platforms. So again, we anticipate that should increase our access to testing and improve the turnaround time, at least through U of R labs. I do not know if Rochester Regional has also purchased those platforms. I would not be surprised if they have. I just haven't heard. But we're still, compared to where we were, say, a month ago, our utilization of testing is far less than what it was even a few weeks ago. Oh, there you go. The legal. Oh, okay, there you go. Okay, so it was illegal. So Cuomo can't go buy it from the state himself, and probably doesn't matter now with the Biden administration trying to come up with a more equitable distribution plan to begin with. So, but if it's illegal, then that makes it that much easier. So anyway, so testing should not be an issue. The anticipation is that the turnaround is improving and it will continue to improve further. Some of the modalities that have been utilized that had a little bit longer processing time will go now to kind of tier B, which should mean that all testing that is done will be in that kind of high throughput testing circuit. So that should improve that for weeks to come. As far as vaccine, we are still in a bottleneck and paucity of vaccine availability. There is a bit of contention right now that the state withheld a large chunk of the vaccine supply for the state pods that they opened. My understanding is that may have been forecasted to continue, even as the distribution plan to New York State was slightly less than what we had received in the first couple of weeks. So several folks have reached out to me asking, are there new links for 1A healthcare providers to get access to the vaccine? Unfortunately, the answer is no. So at the moment, there are no new first dose clinics being opened because there's not enough vaccine supply coming in. And the vaccine supply that is coming in is largely being used to provide second doses for 1A or to provide first doses to patient populations as prescribed. So remember, again, some of the vaccine comes specifically earmarked that you must use this for 1B and 1C, meaning 65 and older patients. So in that case, the local vaccine pods do not have the authority to use that for 1A providers if it was earmarked specifically for patients over the age of 65. So for those who still need vaccination who are on this call, my hope and expectation is that next week may bring a different day. But as of right now, the links that did exist are no longer, and there will be new links forthcoming, but it will depend on vaccine availability. So we will keep you updated. Hopefully by Monday, we'll have a little bit more information about new vaccine clinics, as we're hopeful that next week will potentially bring a little bit more vaccine into the region. But for this week, there's nothing new for right now. Otherwise, we have had some internal conversations, again, hoping and anticipating that practices will be able to start administering vaccine themselves in the not so distant future. We've had some conversations internally about some kind of key strategic points. So for instance, there are low waste syringes that can help maximize the amount of vaccine that you can get from each vial. So with those syringes, you can get 11 doses of Moderna out of a 10 dose vial. In some cases, they're even able to get 7 doses of Pfizer out of a 5-dose vial. As you can imagine, those syringes are pretty short supply at the moment, but with the anticipated invocation of the Defense Production Act, those types of things will probably come into greater supply. So making sure that we can order those to try to maximize our use. At the same time, one of the other key points that we have to consider is the state and federal government have thought of vaccine distribution in terms of vials. So if you got 10 vials of Moderna and you were able to pull 11 doses out of it, but the next vial that comes, you're only able to pull 10 doses out of, then you're going to be 10 doses short because you got 11 out of the first 10 vials, but yet those patients are coming back for second dose and you still only got 10 vials. So there's some logistic considerations in that we'll try to put together some at least words to the wise thought processes that people need to take into account as we move into potentially vaccinating in the practices. And we'll try to have that ready for you before that opportunity goes live. At this moment, I don't have any timeline as to when that would be. With the shortage of vaccine that we're seeing, I don't think they're going to be looking for new vaccination sites anytime in the near term. So I wouldn't even think next week would likely be the time frame that practices will receive vaccine. But as soon as I make these projections, I get proven wrong. So right now, if I had to guess, I would say the earliest I would anticipate you guys, or most of you guys, receiving vaccine to administer in your practice would probably be 1st of February. But that may change. We'll see how things go. Other than that, our next PPE distribution should be next week. Renee is nodding at me. Probably the request has already gone out.
Yes, it is. Kevin is incredibly efficient.
As always. So please make sure you return that for the distribution next Wednesday. And starting next week, we will go back to our Monday, Wednesday call cadence. So we've just kind of got out of sequence for this week because of the holiday and the inauguration and all those fun events. With that, I think I've covered everything I needed to talk about. LJ is already shaking her head at me.
You're so fast. That was impressive. I really don't have anything new to report. I think just a couple of questions have been coming. The return to play for pediatrics is going to be the end of me. And many of us, I think, but there still have continued to be questions about patient symptoms and when patients can start the evaluation process with their primary care provider. So I'll try to do this in 3 sentences. So once a child or an adolescent has been released from isolation, so ideally this is 10 days post their diagnosis or the start of their symptoms, and accounting for the fact that they've been fever-free for greater than 24 hours, that is the time at which they can come in to see their PCP to be assessed to see if they have low, moderate, or higher risk kids already have been identified because they were in the hospital. And you can do your assessment and then either start the return to play or refer them for an EKG or to cardiology. The question that came up was actually quite specific, so I just wanted to emphasize there are some practices who have interpreted that continuation of certain symptoms means even though a child's been released from isolation would mean that they can't start this return to play process. And I would just say that it would have to be significant symptoms ongoing, but we are understanding that some practices are saying that patients who continue to have loss of taste or smell cannot start that return to play assessment. I just want to point out, even though we don't see loss of smell or taste as often in pediatric patients or adolescent patients, it can happen, and that can persist for quite a while. That is not a reason to delay assessment or severe symptoms, continued fever, obviously, or significant respiratory distress. I'm seeing that there's a question that just appeared in the chat, which I don't understand. We've heard of schools telling their students that they must go to acute kids urgent care for testing. Okay, that's a different question all entirely. I think that we will try to make it clear to the schools based on the meeting that we have tomorrow, that practices are doing testing, that patients should be connecting to their primary care practice initially. And then if they are directed to go elsewhere for testing, they can do so. That is the messaging we've had all along. We will do our best to continue that. We appreciate the work of the urgent care centers in supporting this, but we want our families to be connecting to their primary care practices first. So that's it if people still have questions about the return to play piece. I just want to, it's almost as if interpretations are kind of developing on their own, and that's making it very confusing. The goal is to try to get kids back to full activity as quickly as possible, but to just do it with a little bit of caution and assessment, and then an eye on them as they are returning to full activity. That's it. I got nothing else today, Chad.
That was quick and easy. All right, Renee, the show is yours.
I got nothing.
Nothing. Wow, that was easy.
Everyone gets out early
I
today.
was about to say, everybody gets a spring break from COVID. Not very springy outside, unfortunately, but
Not a break.
Any other questions that folks have, or things that we didn't cover that folks have issues or concerns about? Chat.
I guess there is one thing we could mention, and this will be in today's email as well, is that URMC is making some resources available for folks with questions about COVID vaccination for pregnant or lactating patients. There's an email address and a phone number that folks can use to send their questions to, and we'll be publishing that in today's email. So you can look for that to come.
Yes, indeed.
Great.
There, I contributed.
Woo. That might be the most important thing we said today.
Probably.
All right. That's all. Okay, nothing else. All right, so we'll call it early. Everybody gets some time back in their day. Go enjoy their lunch or do whatever you wish to do. So we will see you guys on any news on COVID vaccine for kids. I think that's going to be fall. I think they're starting to enroll in trials, but it'll probably be at least 4 to 6 months, I think, before we see that, based on the timelines I've heard so far. LJ, you're probably closer to it than I am.
Yeah, no, I think you're right on that. I think the only other question about kids is what about the kids who are 16 and older who have chronic health conditions? And I think that, again, they do fall into a different bucket than children in general. So as we know more, as there's more vaccine available, we'll have more information to give to our healthcare providers about that to inform their families.
Absolutely. All right, guys. For now, we will adjourn. We'll see you back here at Monday. Have a lovely weekend and more to come.
Bye, everybody.
Bye, everyone.